like to introduce and welcome our next speaker. Our next speaker is Matthew Myers. I got to find your title, Matthew. It's all this it's credentials. Got to get past them. Biostatistician with Schultz School of Medicine and Dentistry, Western Vanier, Canada, graduate scholar. Welcome, Matthew.
Thank you. I wear a number of hats, so it's always a little bit of a struggle for people to give my introduction. Can you hear me okay? Great. First of all, I'd like to say thank you. It's great to be back. I'm also a Queen's grad. It seems like everyone here is today. I wish I had more time to spend in the city. I was in last night and leaving after I speak. But I got to see the train station and Denny's, both of which bring back a lot of memories for me. I'm not a clinician, so I'm working on a PhD currently. So I'm really an epidemiologist, and not official yet, but will be. And with a sort of special interest in health economics. So I'm a systems guy. Everything that I do and all the work that I've been doing is taking a look at the system of care and trying to find ways that we can improve it and improve the patient experience so that we can make sure that we're taking care of the people that need these services. So this is a slide that I use regularly to just kind of introduce the kind of work that I do and how I go about thinking about the system. So for the average patient that experiences a stroke in Ontario and they enter into the hospital, this is just a crude look at the data to say, here's what they should expect. So on average, patients spend 12 days in an acute care bed. 4 of those days approximately are ALC. For those patients that are fortunate enough to be referred on to rehabilitation, they tend to spend about 31.7 days in a rehab setting. On average, 2 of those days are ALC, but very few facilities across the province provide 7-day-a-week therapy. So if you look at the 31-day period, or 32-day period, 8 of those days are weekend days, so those are days that they're sitting in a bed not getting therapy. This is where it gets even more challenging. Very few patients in the province have access to CCAC, to good rehab through CCAC. The provincial average for patients who do access those services is 3.9 visits total, rehab visits. And on average, patients spend 20.5 days waiting to get into those services. So when you sum all of that up, the average patient in our system spends 68 days in the system, and they spend more than half of that time waiting to get services. I think this is a real problem, and I was really struck by Dan and Steve by the number of times that they mentioned how fortunate they were. Fortunate to have access to rehab or to research projects that could get them rehab, have access to private practices, to have access to funding or insurance coverage that could pay for some of these bills. And it's, I think it's really telling to hear their stories, because when I hear that, I think this is a system that's failing our patients, when you have to be fortunate to get good care. So that's kind of the perspective that I take with this. I'm going to start walking you through the numbers. A lot of the stuff that I do is with the Ontario Stroke Network. We've also been doing a lot of research elsewhere. There will be a lot of numbers. There will be a lot of dollars. I know that's boring and it's hard to stomach, especially after lunch. I'll try to kind of hit this at a high level because I want to demonstrate the point. And so for anyone who's interested in more details of how we've gone about it, the methodology, on that first slide, there is a link to a report that we submitted via the Ontario Stroke Network that is available online. So most of your questions can be answered through that. And you, by all means, send me an email if you have any other questions. So I'm going to kind of try to hit it at a high level. So here's what I'm hoping to do. I'm going to start by talking about the provincial economic evaluation that I've been doing with the Ontario Stroke Network. I'm then going to dive into some of the Southeast data. This is by no means a complete economic evaluation of the Southeast. It's a start, and I hope to kind of work with you as we go forward to think about this. Then I want to talk in real detail about practical implications. I think the implementation of this stuff is the most interesting part of it, so I want to spend some time talking about my thoughts on that and what we're thinking provincially. And then finally I want to touch on the funding reform, because as you will all know, and especially the administrators in the crowd, this is coming. There will be a funding reform, and I think it's really going to change the way that we think about providing services, and I hope in a positive way. So this is the report, and as you can see, there's the link to the report online. The objectives of this report really are to build a high-level business case. I don't think that dollars should stand in the way of best practice care, and so what we wanted to do is to take a look at the best information that we have for how patients flow through the system and to infer what potential is there for change. What can we do? Now, these things are not going to be easy to do, but what are the possibilities? We also, as part of that process, are constantly coming across things that are challenges and there are barriers, and areas where we need further evaluation to get a better sense of how we can go about making these changes. So you will have seen this over and over and over again, and I'm going to beat you over the head with it one more time. What my job was to do was to take the provincial recommendations for stroke rehab and to apply them to patient data to see what impact it would have if we were to actually meet these targets. So in very specific terms, what are we talking about? We're talking about earlier transfers from acute care to rehabilitation. The targets that have been set are an average of day 5 for ischemic stroke patients and an average of day 7 for hemorrhagic strokes. Once patients get into inpatient rehab, greater therapy intensity, as Dr. Bailey mentioned this morning, is very important. So what is the recommendation? We're talking about 3 hours of therapy a day, 7 days a week. This, I will not pretend that I'm not biased. I think this is the most important piece. Community access, so access to outpatient and community-based rehabilitation services. And what's really nice about these recommendations is they're very specific. 2 to 3 outpatient or community-based rehab visits per week, per discipline as necessary, for 8 to 12 weeks. And you can kind of recall, on average, patients are getting 4 visits total. What we're talking about here is true community-based rehab. And again, I think it speaks to what Steve and Dan were talking about when they were talking about walking out the door and not having access to the services. This is something that should be available to everyone who needs it across the board. So that's the recommendation that I'm working off of. And then the last one, and something that I'll speak to a little bit is just making sure that everybody has access. And this has come up, it's a theme that's come up over and over again today. So I'll touch on some research that we're doing around that. So here is our system in schematic form. It's not perfect. Patients can transition from anywhere to anywhere, but this is just to demonstrate kind of the major pathways that we've considered in the report. So we're looking for patients coming from acute care to be discharged either to complex continuing care, inpatient rehab, outpatient rehab, some community rehab, or directly home. Now, I've got some of these boxes highlighted and some not. You'll see that the ones that I have not highlighted are patients who are discharged directly from acute care to long-term care, and patients that are discharged directly from complex continuing care to long-term care. The reason is that they were not included in our economic evaluation, and that's not to suggest that we don't think there's tremendous potential in these groups to really have an impact. But what I didn't want to do was to present an economic model. We've all seen the models, right, that if you only reduce days by this much, we'll save $5 billion and all of our problems will be solved. This is a really challenging group. So I didn't want to overestimate our potential, and so these patients often spend a long time in both acute care and in rehab, and I didn't want to overestimate, but again, not to suggest that there isn't tremendous potential here. So I've focused my evaluation only on patients currently going through the rehabilitation system. So here's what we did. We basically broke it down by sector. We went acute, rehab, outpatient, and tried to take a look at if we were to implement these recommendations, what potential is there for changing patient flow and for cost reduction or for freeing up dollars. So again, if we were to achieve an average target of day 5 for all ischemic stroke and TIAs being discharged to rehab or home, a day 7 for hemorrhagic, and by doing this, we're to eliminate ALC days, what impact would that have? Here are the costs that we looked at, and again, I think this is also really important. Pulled this information from the Ontario Case Costing Initiative, from their data. These costs include your sort of standard hospital costs. So we've taken out surgical, medical interventions, diagnostic imaging, that sort of thing. if we're talking about transferring patients on day 5 to rehab, all of that stuff has to happen. So we're not going to be able to eliminate any of those costs. Those things have to happen, they just have to happen in the first 5 days. So I didn't want to overestimate the cost, but if you take all of that out and you look at how much it costs just to keep a patient in the bed, the number is about $600 a day. Keep that in mind because it's very similar to the figure that we have for complex continuing care. It's very close to the figure that we have for rehab. And I think that the point there is that a patient in a bed costs about $600. So let's stop talking about bed designation and start thinking about the services that should go along with that bed. So these are the numbers that we used. When you total it up using all of the information that we have available, we estimate that there's a potential to eliminate approximately 22,000 ALC bed days a year and 23,000 additional acute bed days just by getting patients into rehab or home by the target date. If you infer potential for freeing up resources, that represents about $26 million. I'm also very cautious to not suggest that this is savings. These are not savings. These are dollars that can be used elsewhere in the system. Okay? So if I say savings, somebody throw something at me. The inpatient rehabilitation piece is more complicated, as it should be. So what we're looking at is a recommendation of getting patients in, getting them 3 hours of therapy per day, 7 days a week while they're there. Our assumption then, and this is kind of how I've gone about it, is taking a look at what therapy staff would we need to be able to provide that level of therapy. So if you assume that a therapist can spend about 6 hours of their day in direct therapy, then each therapist can have no more than a one therapist to 6 patient ratio. They can't care for more than 6 patients in a day if they're going to be giving them an hour of therapy. For SLP, it's a little different because only about 50% of our patients require SLP services, so that the estimate is about 1 to 12. But just to give you a sense, these are the numbers I'm working off, and this is how I'm trying to think about this. What resources do we need to be able to get to where we've recommended patients get, the intensity that patients get? The other thing when you're modeling this stuff is that we want to, again, be accurate as possible, and we want to take into account all the things that clinicians say, yeah, but, yeah, wait a minute. It's nice that you can say, well, we'll save some dollars, but it's going to be more challenging, or it's going to be more difficult, or we don't have enough staff. We wanted to factor some of that in. So when we were looking through the model, the assumption now is that if patients are coming to rehab sooner, they're going to be a little bit more severe. They'll have more acuity. So we have to account for that. But when we spoke with the stroke reference group, there's also a tremendous feeling that there's potential by giving patients more intense therapy to improve their rate of functional recovery. Certainly weekend therapy will help with that as well. And if we actually have a system that has appropriate outpatient and community-based resources, that we can transition patients through rehab much quicker and give them the support that they need. So there is a sense that we might actually be able to reduce the length of stay. So we wanted to kind of account for that. Dr. Bailey introduced the RPG groups. I'm just going to put it up there again to remind you that this is how we've broken things down in our evaluation. So there are a number of things that, this is kind of how we went about it in very general terms. And again, the methods are all online if anyone wants to go at it in greater detail. The RPG groups, there are 7 of them. They rank patients based on severity and anticipated length of stay. So what we're going to do for this model is we're going to look at patients that were coming to rehab in fiscal year 2010. And because we're inferring that they would get there sooner, we're also going to assume that they would arrive in the RPG that's lower. They would require that length of stay. So we've already up front said, okay, they're going to be more severe. They might need a little bit of longer length of stay. So we've done that. Then we worked with a stroke reference group to say, from a clinical perspective, what impact do you think greater therapy intensity could have? What's reasonable? And they were the ones that generated these sort of estimates. So if we can actually reach 3 hours of therapy a day, and if we can actually give them 7-day-a-week therapy, the suggestion was that we could reduce length of stay by 1 day per week. Okay, so that's coming from the stroke reference group. So that was built in. The other piece that I think is really important, and I'm going to come back to this in a few different ways, is that we know that there are a lot of patients going to inpatient rehab that don't need to be there. And not because they don't need rehab, but because they could get that rehab in the community. So we wanted to come up with a number. How can we identify which patients meet these criteria? And it's really challenging, and I don't want anyone to think of this as gospel, but the number that we came up with was a FIM score of 100. These are patients that are very high functioning, and by definition, interestingly enough, that highest functioning RPG group, patients in that group, to get into that group, you actually have to have a FIM of 100. So, and there was a lot of discussion about that mildest group being the group that really didn't need to be there, and these are the clinicians that were telling me this. So we set that as kind of the target. And again, it speaks to what Dr. Bailey was talking about. If we're thinking about putting patients into rehab at a FIM of 80, that gives them 20 points that they can gain before we would say, okay, that's enough, now you're ready to go back to the community. Not perfect, but it's something, it's what we used. So again, here's your rehab per diem cost estimate that we used, $600 a day, right? It's about the same cost. This is a really big table, and I'm going to draw these are the results that we came up with. I want to draw your attention to a few, I think, really important things. The first is this column in the middle. I've been doing a lot of work directly with ISIS, and they're able to access lots of really good patient data. So one of the things that we did is we took a look at the patient's FIM at discharge, and we used a statistical method, an algorithm, to infer how many days patients were spending in inpatient rehab beyond a FIM of 100. Okay? And remember, that 100 is because these are, at that point of 100, we think they're pretty high functioning, and they could probably go home. When you do this, when you look at actual patient data to see how many days patients were spending in inpatient rehab beyond a FIM of 100, the numbers are staggering. We have a lot of patients that are staying in and being discharged with FIM scores as high as 115, 120. And what I'm hearing in some of the focus groups and people, I can see people nodding here too, so I think you're probably going to be in agreement. A lot of this reflects the fact that there are no services to discharge them to. So clinicians feel uneasy sending them home, and we keep them in inpatient rehab beyond a point that they really need to be. The other thing I really want to highlight, because this was really surprising with this, is if you look at the bottom of that column, 1367 and 1130, those represent the number of days that patients in the lowest RPG, so with the most severe strokes on arrival, spent in inpatient rehab with a FIM over 100. So this is stunning, right? There's all this discussion about should we be giving severe stroke patients rehab. There are a lot of patients in the province that are entering into rehab with very severe strokes that are making tremendous functional gains and are being discharged with a FIM over 100. That really speaks to the benefit of rehab, and I think it's a really important point when we just get into this discussion of should we be providing rehab to severe stroke patients. This certainly feeds to that discussion. There is a lot of potential for these patients, and a lot of them do very, very well. So these two columns here, the third one from the left is the current length of stay in inpatient rehabilitation. On the right, after we went through the methods and incorporated all of the things that I sort of mentioned before, these are our targets. This is what we anticipate for these RPGs, are probably reasonable lengths of stay for those groups. I want to point this out as well. So this is the length of stay for patients in that mildest group, the mildest patients. So they spend on average 15 days in rehab. So I want to point that out because I'm going to come back to it later. But I also want to draw your attention to the fact that if you go to the right of that, our anticipated length of stay for those patients is 0 days because, again, there was consensus that they probably don't need to be there in inpatient rehab. I don't know that that's truly the case. I think that there are some there may still be some that need to go, but in general terms, we think these patients can get their care at home. So when you work through all of that and you look at the difference between what we think are the reasonable targets for length of stay and what their current length of stay is, there's a potential to free up about 17,000 rehab bed days. And when you multiply that by the per diem, we're talking about $10 million in cost that could be made available for spending elsewhere in the system. The next piece, which is really important and again has come up, is that this discussion of slow stream rehabilitation and complex continuing care. So there is a recommendation, as Dr. Bailey mentioned, that many of these patients don't need to go to slow stream rehab. They would be better served in inpatient rehab. So we wanted to go and sort of reflect that and take a look through the data. It's really challenging to get a sense for which of the patients in complex continuing care truly require complex continuing care and which of them are there to get rehab. We did a survey in 2009 and found that a lot of the facilities that provide complex continuing care are using it as a rehab proxy, but it's hard to tease out which patients are which. So we wanted to try to at least sort of illustrate there is some potential here. And the numbers, again, are pretty big. So if you look at the number of patients in, I believe this is 2010, that were discharged or admitted to complex continuing care, it was 1227 across the province. This was just with stroke. We assumed, and it's a big assumption, but again, it's something, that any patient who went to complex continuing care and ultimately was discharged home was likely someone who is a candidate for inpatient rehabilitation. It's a big assumption. But we just, again, wanted to say, to reflect the fact that not everybody in complex continuing care should go to inpatient rehab. It's only a portion. If you look amongst those patients, there were 355 then that went home. Their length of stay in CCC was 84 days, which is actually down from 90 the year before, and that's trending down. If we were to assume then that they would experience the longest anticipated length of stay based on our benchmarking for RPGs, that would be 50.7 days. That results in a reduction of about 12,000 days in hospital by just putting them into that inpatient rehab bed. So if you start looking at the differences between the costs of those services, it would be talking about elimination of 30,000 complex continuing care bed days. Those bed days, though, would be spent then in inpatient rehab, so you need an additional 18,000 inpatient rehab bed days. The difference in those would be about $6 million in funding annually. Again, that would be made available. We wanted to really reflect that implementation is important. So this piece is starting to, what I was talking about before, thinking about staffing. If we're going to provide 3 hours of therapy a day, 7 days a week, you need the staff to be able to do it. So we wanted to take a look at some of the data that we had to see if we could make inferences to how much it would cost for us to make sure that we have those staff available. So from our survey in 2009, we looked at all of the rehabilitation hospitals across the province, and we looked at how many therapists they had available for stroke care. I'm going to go through this next little bit relatively quickly again. You can go back to the report. So we worked off of those numbers. We basically then took the current staffing level and looked at how much it would cost for us to get up to ideal staffing levels. So no more than 1:6 ratio for PTOT, no more than 1:12 for SLP. We factored in the need for weekend therapy, so assuming that full model of staff Monday to Friday that we were working off of, we just multiplied that by an additional 2 days, so you have additional staff available on the weekend now to provide care. We added a premium for that care because they make more money on the weekend. The other thing that we heard early on was that, and this is a big challenge, it's really difficult to cover staff that are away on vacation or sick. That's a really big piece, and we need to factor that in. So in our most recent iteration, we built that into the estimate as well, assuming that each therapist would take off, but would be away for about 6 weeks, and that would be a combination of sick time and vacation time. So we built in the cost for recovering those staff. And when you work through the numbers, again, it's a great big table, but the punchline's at the bottom right. So we think that looking at what we have currently and what we would need, it would cost us about $11 million annually to hire those staff to make sure that we're in a place where we can actually provide the therapy that we're recommending. So when you add all of this up, it becomes really interesting. So there's discussion about eliminating some of the CCC beds that are not being used appropriately. So there's about 30,000 of those. It's a pretty significant number. When you look at the impact on rehab beds, we actually, these numbers, again, they're very high level, but they suggest that we probably need about 3 more rehab beds a year. And really, I mean, that's nothing. That kind of works out, in my mind, to the fact that the resources that we have in inpatient rehab are probably sufficient to care for the patients in kind of a best practice model. It's just making sure that the right patients get into those beds at the right time, right? So really, the resources are in the system. It's just using them better, I think. And when you work through the dollars, that works out to a net $5 million annually that, again, could be used to help to implement some of these changes and help to improve the system in other ways. So we're getting up there in the dollar figures. This is something that was done as part of this project that I'm really proud of, and I think it really speaks to everything that we've been talking about. So we wanted to get a sense. I'm very interested in the patients that are not accessing services. Right, and this came up earlier this morning. There's a lot of talk about what is our length of stay for people that are in the system. What about those people that aren't in the system? Where do they go? What happens to them? So what we did, we designed this study looking, again, using Ontario stroke audit data, which is a very valuable resource. They collect really good clinical information about all of the patients, or many of the patients that have stroke, so it's a random sample. What we did is we then took that information, we applied what's called a propensity score. Basically, what it does is it factors in some of their clinical information and allows us to match patients one-on-one. So they get matched based on clinical characteristics, so similar age, similar sex, similar functional scores, that kind of thing. We also match them based on their Rankin score, which is a functional measure, which is, again, really important for dividing these patients out. So this method, this technique, allows you to take patients who, in theory, are clinically similar and to take a look at those patients that went to rehab and those patients that didn't go to rehab and see how they fare. And what we looked at were, we only have access to certain things, but we looked at their mortality rates in 2 years, their discharges to complex continuing care or to long-term care, and total cost. So this is all hospital costs, this is drug plan costs, this is all of their OHIP billing, everything, up to 2 years. When we did this and we went through all of the numbers, what we found is that it really matters, the level of severity of the stroke really matters. So if you look at patients, what we have deemed to be the mild stroke patients, so this would be a Rankin score of 0 to 2, so they're the mildest patients. Patients who went to rehab were actually more likely to go to complex continuing care, although it was a difference of, I think, 5 cases in the year, so statistically significant, probably not clinically significant. Really, there was no difference in long-term care or mortality rates between the two groups, which kind of fits, and they were much more costly than the patients that didn't go to rehab. And most of that cost was the cost of inpatient rehab. So I think this kind of supports our argument that some of these milder patients really don't need to go to that inpatient rehab bed. They could go and get their care elsewhere and really have the same sort of clinical outcomes and from a cost perspective, probably cost us less. For moderate stroke patients, it was interesting. So this is where we did start to see some differences in some of the clinical indicators. Again, they're not great outcomes, but there was a statistically significant reduction in mortality for patients that went to rehab. So they're less likely to die. It did cost us more over 2 years, but the difference was, I think, about $5 per day survived. It wasn't a tremendous difference. What I was most interested in and most excited by was that most severe group again. In patients in Rankin scores 4 and 5, those that went to rehab were statistically significantly less likely to go to complex continuing care, to long-term care, or to die within the next 2 years. And when you look at the cost between the group, looking at all costs built up, it's actually cheaper to send them to rehab. And although it didn't reach statistical significance, it was close. It was a p.07, so anyone that knows stats will know that that's one of those, we're so close, right? So we would suggest that there's a trend towards statistical significance. But it's right there. I mean, the numbers suggest that really it costs us less in raw terms to send these patients to rehab. I think that's a really important message. All right, so moving on through this model then, the next piece is outpatient and community rehab. So again, we're talking about 2 to 3 visits per discipline per week, 8 to 12 weeks. We had to work through some assumptions to get a sense for what proportion of patients need these, and I think this is really important, and it's an area where more research needs to be done. Based on the best information we had, we assume that about 13% of patients that are currently discharged directly home from acute care would require rehabilitation services. There's some debate about that number, as there should be. For the purposes of the model, I assume that 100% of patients that went to inpatient rehab should also go to, on discharge, should have access to outpatient or community rehab, and I think that speaks to the stories you heard before. It should just be there by default, no questions asked. It was really challenging to get a sense for how many patients are going to outpatient rehab. It's one of those sectors we don't have a lot of data for, so we assume that there are about enough resources to care for half of those patients, but it's really challenging. And for people in the CCACs, close your ears for a second, what we assumed in our model was that CCAC does not provide any rehabilitation in the community at all. Now I know in this region you've done a ton of work. It's a little different in other regions. So as you saw from the numbers, patients on average get about 4 rehab visits from CCAC. And so what we've heard a lot from people in other regions especially, is that they're not really providing rehab. It's more of a safety assessment, looking at the in-home assessment, and then they're out. So for the purposes of the model, we just assumed that there was nothing there, and wanted to take a look at, how much would it cost to build that program from the ground to be appropriate to care for all the patients that need it. So when we worked through the dollar figures, we worked with a number of organizations. Here's the cost that we figure a full rehab program would cost. We wanted to talk in terms of different programs. So the first column are patients that would be cared for in outpatient rehabilitation clinic, which is cheaper than going to the home, and only require PT and OT. The next one is outpatient rehab for someone who requires all 3 services, so SLP is included. The next one then, the next row I should say, is community rehab without SLP, and it becomes a little bit more expensive. Again, this reflects travel time, right? So if you're going to travel to the home, that cost has got to be incorporated into it. And then the last one would be a full community rehab, so PT, OT, SLP. So our estimate, these are the estimates, and it's about $10,000 for the most expensive program. And just to put that in rehab terms, equals about a 17-day length of stay in inpatient rehab for the most intensive community-based rehab program. And I'll remind you at this point, 15 days was the current length of stay for RPG 1160, the people that the stroke reference group think don't need to be there. And so I think that this is really telling, and we heard this at our clinic, or our program in London, that one of the challenges with reducing these lengths of stay, and I think it gets to what Dr. Bagg was talking about with his work, is that if a rehab hospital is going to go to the trouble of admitting someone, they're going to keep them for a while. And we found at Parkwood that we couldn't cut our length of stay down lower than 2 weeks because it took about 2 weeks by the time they got some assessments done, started doing something, and then got the discharge taken care of. And so I think in some ways it's almost an all or nothing. I think although you're doing great work, but you spoke to this earlier, that some of these patients, we need to just avoid that whole inpatient admission altogether, and there's really tremendous potential there. So this was, again, some work that we were doing with ISIS. So as I mentioned before, it's cheaper to provide care in outpatient clinics where the patient comes to the hospital. So the question becomes, for how many patients is this a reality? And there are a lot of factors that have to go into this, but we wanted to just get in general terms a sense. So we worked off of the survey that we had previously, and we looked at where the outpatient clinics were in the province that had some stroke expertise. So expertise was defined as more than 5 stroke patients a year. And all the clinicians in the room will laugh. That's not really stroke expertise, but it's something. So that was the criteria we used. And then we plotted for all the patients that were discharged home to their primary place of residence, how far was that from an outpatient clinic? And we looked to see how many of those patients are within 30-minute drive of an outpatient clinic. And 88% of the patients across the province are within 30 minutes of an outpatient clinic. Now, there are, as I keep repeating, there are concerns with some of these analyses, and everyone says that, and it changes from region to region, and you are absolutely right, but I think it really speaks to the fact that, by and large, this is a good way to go about providing care, and for patients, even for patients that have transportation issues, this is, I think, is where some creativity needs to come into play. If it's cheaper for us to get them into inpatient to outpatient rehab, it might even still be cheaper for us to go get them and bring them in, right, if they don't have transportation. So just, again, food for thought. So when we work through applying that to the provincial numbers, our estimate is that probably about $11 million annually needs to be invested in these resources to be able to get us up to where we need to be from a best practice standpoint. So when you add all the numbers up, the potential, remember this is all about potential. The potential's there. It's incredible, the potential that's there. And when you add all the dollar figures up, the net result is about an estimate of about $20 million that could be made available for reinvestment elsewhere in the system. Right? This is not dollars we're saving, although that's what the ministry likes to think. These are things that will need to, there will be costs that will need to be put back in to acute care hospitals in some places, to rehab, but certainly in the community, the reintegration, all of that sort of thing. But there's potential there. So again, I'm certainly not going to pretend that this is a complete Southeast evaluation. I hope to continue to work with you as you go through this, but I just thought I'd show you some of the numbers that we have from your region fitting with this. So looking at the acute care piece, again, only looking at patients who are returning home from acute care. In 2010, those patients occupied 601 acute ALC bed days and 758 additional acute days beyond the recommended targets. For those patients who were transferred to rehab, the numbers are 255 ALC bed days and 672 additional acute days. When you multiply that by their per diems, you get about a $1.35 million that we spent on patients beyond the recommended targets. These are the inpatient rehab numbers then. So you've got the number of patients for each RPG, their current length of stay and the target length of stay, and then the delta. And when you sum all of the differences, what you get is an anticipated 1,854 rehabilitation bed days that could have been made available if we were to actually meet the targets that we had recommended. Looking at the complex continuing care data, it's challenging provincially, it's even more challenging regionally. So just taking the provincial numbers, applying those proportions to your region, the estimate would be that there would be about 14 complex continuing care patients per year that could be transferred to rehab, so it might have been candidates for inpatient rehab. Don't jump all over me. It's really challenging to look at this, but I just wanted to illustrate, what the numbers suggest. So the potential reduction in complex continuing care bed days would be 1182, and you would need about 700 additional inpatient rehab days to care for those patients. So when you work through those numbers, that suggests that in the inpatient rehab sector, by meeting these targets, you could have another about $1.35 million freed up for spending elsewhere. So when you total that, there's $2.7 million that could be made available. So what are we going to do with it, right? I mean, that's the made available part. Trying to look at now at the other part. Where do we need to put those dollars to achieve some of these efficiencies? So if you look at stroke staff, trying to figure out how many staff we would need in hospitals, there are about 643 stroke admissions per year. So based on that, and built off the same assumptions we used provincially, the complete staffing complement you would need to provide the intensity of therapy that we've suggested to those patients would be the numbers you see there, and that would cost approximately $1.6 million a year to get your staffing up to the point where you could provide that level of intensity that we suggest. For outpatient and CCAC or community-based rehab, the numbers, again, based on those numbers we were using provincially, would be about 40 patients coming from acute care that would need services, 133 that were coming from inpatient rehab, so a total of 173 patients a year need to go through these services. Again, I said that the numbers we were looking at, we use that 88% as outpatient candidates. I know that this region is very different. There's a lot of rural patients, rural population. So let's just assume for your region that you would need, that about 50% of patients would need SOP, as is similar to the provincial model, but that 50% would need the community rehab. If you add those numbers up, that's $1.2 million. So for the bean counters in the audience and the people that are going to raise their hand, that equals 2.8, not 2.7, but what's $100,000 between friends, right? But no, but to be serious about this, there are a number of different ways that you can go at looking at these numbers, and with the information I have right now, it's really challenging to get a sense for what the system might look like, how you would go about it with different variation between facilities. But so I just want to point out the fact that these dollar values are building your system from scratch, assuming that there is nothing in the community and there is nothing from a rehab perspective in any of your hospitals. And we still are right about even. So I think, again, it's just the reason I did it in this way is I want to just demonstrate, if there's a point, is that the dollars really are in the system. It's just reorganizing those dollars to become more efficient, to get better patient outcomes, better patient care, and to see benefit from a financial standpoint. So those are how I went through looking at the numbers. So this, I think, is probably the more interesting piece. So all of that is very theoretical. It's all very high level. It's using the best data that we have. We've gone to great lengths to try to build kind of an accurate model. But at the end of the day, what you get is an accurate model. We have to start thinking now and about how are you going to go about achieving this. So I wanted to talk about some of the principles that in some of the work I've been doing in other regions that we've been starting to tackle and starting to address. Every time I go to speak to someone, they ask me some really good questions, and that gets us going back to the literature and to the expert panel to say, well, what about these things, and what are you thinking? And so I thought I'd share some of that with you today. So how can we go about achieving some of these efficiencies? Really what it boils down to, what all the best practice recommendations boil down to, are better processes of care. So the first one that I really want to talk to about, and I think is really important, is stroke expertise. So you've heard time and time again the importance of getting patients into a stroke unit. And we've had a lot of discussion in both regionally and the ministry as well, as we talk about funding reform. What is a stroke unit? What does it mean? And it's not enough to just put a sign on the door that says stroke unit, right? We have processes of care that go along with that. And so we've done some work looking through the literature to see what definitions are being used, and you get terms like geographically distinct that get thrown around. But what all of them essentially boil down to is it's having staff that are expert in managing stroke patients. That's a really important piece. So I want to talk to that a little bit. The next thing I think, and as you'll see, it continues to come up, is timely access to care. It's not enough to just have the services in place. You have to have those services in place when the patient needs them. And then finally, that appropriate intensity of care is really something that I think is important and needs to be a focus. So when we talk about stroke expertise, like I said, there are a lot of things that you can think about. And these are some of the best discussions I've been having lately. What does it mean? So is it years of experience, right? I mean, we have stroke experts, people that have worked in the field for 35 years. They would certainly be a stroke expert. How do you measure that, right? How do you measure that kind of at a high level? What about specialized training? Have you taken courses in stroke? Right? How do you quantify that? And one of the measures that's used most commonly is just patient contact. So how frequently in your day-to-day activities are you caring for stroke patients, and how much of your caseload are patients that have experienced a stroke? And of course, the concern with this is that if you take a fresh grad and you send them into a unit where they care for 100% stroke, then they are automatically deemed a stroke expert, right? And we know that's not not correct, but it's one way of going about it. So you'll see that there's a reference here that I'm giving, that this is a paper that is currently being published. We were looking at stroke units in Ontario, and the criteria that we used was that the therapy staff needed to be seeing at least 80% of their caseload needed to be stroke. That was kind of what we set as our criteria for stroke expertise. I mentioned that again because I'll come back to it. So when we're talking about stroke, and we're talking about stroke expertise, the volume of patients that a hospital sees is one way of going about looking at this. And there's a lot of work that's been done in the literature to take a look at what role does the volume of patients that a hospital or hospital staff see annually play in patient outcomes. So this is a table that came from a study that was done by Gustavo Sapoznik, using Canadian data. And what you're looking at here is on the left-hand side is the discharge mortality, and on the right-hand side is a 7-day mortality. And it's broken up into groups. So hospitals that saw fewer than 50 patients, 50 to 99 patients, 100 to 199, and then greater than 200 a year. And what you'll see is that there's a trend in decreased mortality as the number of stroke patients a hospital admits goes up. So there's really sort of leads to that sort of assumption that more is better. the more patients you can see annually, the better. The more access your staff has, the more opportunity they have to become experts in stroke care. But what of course people always ask me is, well, what's the number? What's the minimum number? And we don't know. But I do want to point out, and I'm going to work towards this, I just want to point out the fact that for those hospitals that admitted more than 100, so both the 100 to 99 group, to 199 group, and the greater than 200 group, were had statistically significantly fewer deaths than those hospitals that admitted fewer than 50. And for those that admitted 50 to 90. So it seems like 100, 150, 200, somewhere in that range, there's something going on. So let's look at it in a different way. So this is additional research that was done by Ruth Hall, by the ISIS group, and they are working on a publication, but this was taken to the International Stroke Conference. They did the same thing, and they looked at the ISIS data, and they compared volume to mortality. They split the hospitals up into slightly different groups, though. So they looked at what they determined or deemed to be small would be 15 to 120 admissions annually. Medium was 132 to 190, and high was 200 to 456. And when they ran all of their statistics, they found kind of the same thing. Okay, I'm going to work through this really quickly. I'm running out of time. If you look at high volume versus small volume, there's a statistically significant difference in the mortality rates. So for those hospitals that saw the high volume or the medium volume, so more than 130 compared to the small, there were significant differences in mortality. When you looked at medium to high, there was no significant difference. So again, it kind of points to this 130, 150, 200. This is looking at it in a different way. If you're thinking about setting up a stroke unit, here's looking at a number of different volumes. This is using the Canadian Stroke Strategy's recommendations for staffing. So the first column here is 100 stroke patients admitted a year. That works out, assuming a 10-day length of stay in acute care, that would be 3 beds that you would need to care for those patients. If you apply the Canadian Stroke Strategy recommendations for staffing, you can work your way down the list. But what I want to point out to you is that for PT, OT, and SLP, based on patient need here, you can only justify half a PT, half an OT, and 0.3 SLP to those patients. So we're not getting up to that 80%, the 0.8 FTE that we would sort of deem to be stroke expertise. You just can't justify having enough staff in that unit to develop stroke expertise. Once you get to 150, you can, so it's 0.8, but that's 0.8 of 1 FTE, right? So that person, you're now going to be asking your 0.8 FTE by best practice standards to care for patients 7 days a week. So is that practical? The other thing I want to point out here too is when we start looking at assistance. So if you start getting up to an admission of 200 a year, it's only about 250 admissions a year that you can start to justify the use of assistance, which is much cheaper. But you've got to get up to that volume, again, so that you can have stroke expertise in your core therapy staff and you can justify your assistance. This is a different way of looking at it, and this is what we've been doing in some other regions, is to look at what if you take your acute unit and you convert it into an integrated unit, so that you have acute and rehab in the same hospital, in the same bed even. And when you do that, you can see it allows you much more flexibility in your staffing. With only 150 admissions a year, you can go from what would have been a 0.8 FT for PT up to 1.1. So you get into a position where you can offer much more expertise very quickly. And that's because patients stay longer, of course, right? So you've got more opportunity. And it does also allow you at a smaller volume of patients annually to justify assistance. So I just wanted to sort of highlight, these are the numbers that I got from your region. So I got information, this I think is from 2010, and these were the admissions, stroke admissions, removing TIA across your region. So there were 9 hospitals that admitted stroke patients. And you can see if we're thinking about that 150 to 200 number as your volume to develop stroke expertise, you've got 1 that gets up to that volume. This is looking at it in a slightly different way. So this is by hospital corporation. And when you do this, all of a sudden you start to see that you've got volumes that are starting to get up into the ballpark of what we're talking about from a stroke expertise perspective. And these are averaged over the last 5 years. And when you look at that, they remain relatively constant over those periods. There's not a ton of fluctuation. So, that's the range underneath is the fluctuation. So again, just sort of food for thought. This is your region. I think that the numbers suggest that you probably can justify 3 stroke units. So I'm going to go through this relatively quickly because I know I'm running out of time, and I think we've kind of hit on this. Timely access to care is critical, and it's got to be something that we're thinking about all the time. So whether it's time from EMS pickup to arrival at acute care, acute to rehab, rehab to outpatient, the services have to be there immediately, and as it was alluded to earlier, I think what this really speaks to is that we need to start talking about the discharge before it's time for discharge and start pulling patients through the system in order to make sure that they're in the place where they need to be at the right time. And I just also want to point that in order to achieve this, because there are fluctuations, we know there are fluctuations seasonally, annually, that it may actually, to achieve this, the best way to go about doing it may actually be to have a surplus of services in some instances. And then again, intensity of therapy, something that we really, really have to focus on. So making sure that it's driven by patient need and by the amount of therapy that they require. So just quickly, I want to touch on the funding reform and what kind of the future will look like. So I sit on the stroke episode of Care Expert panel, and we're working with Health Quality Ontario to develop some of these recommendations for funding reform. I don't know what it's going to look like, but I'll give you some sense. When you take a course in health economics, the first thing that they tell you is that perspective is everything. I like this one. I found this on the internet. I thought that was pretty funny. But it's really important to consider perspective, and I've been sort of working through that with all the information that I have. So everything that I've done to date has been from the perspective of the ministry or a LHIN, so that government body. Who is paying for the services? How much does it cost? How much are we billing the ministry to pay for these patients in the system? So there's a really good business case for them to improve efficiency. From the facilities perspective, this is very different. Right? There's two completely different perspectives. We're now talking about taking patients, moving them through really quickly, giving them high-intensity services, and then sending them, in some instances, to another facility. That impacts your budget, right? And these are the things that differ in some ways between facilities and the ministry. So as everyone knows, quality-based procedures are something that is being worked on, is being developed, and stroke is one of the diagnoses that is being built into that. And the literature around prospective payment and the theory behind this from the ministry's perspective is that it's supposed to promote quality care and improved efficiency. And so basically, your facility or whoever gets that allocation of funding will get a bundle of funding that will be, and will have earmarked standards of care, and you'll have to then be as efficient as possible in providing that care to those patients. But what's kind of nice about it, I think, is that it changes that focus. So from a facilities perspective, it's now going to be in your best interest to get the patient through, get good outcomes, and get them to where they need to be in a cost-effective manner, because then you get to keep the difference. And I know this from experience in working at Parkwood. We've done tons of really good work to be more efficient, and in the end of the day, what they end up being is punished for it effectively because they lose funds and they have beds cut. That should not be the case if this is designed properly. So it's really going to represent a big change, I think. So just kind of in summary, we know there are big challenges, but I think there are really big opportunities. What I'm most excited about is the fact that all of these opportunities can be achieved through better patient care. That's the bottom line here. We're talking about application of best practices, so patients should fare better. But I think providers will actually have the potential to benefit too if it's done properly and the right thought goes into it. So these are my references for anyone that's interested and my acknowledgements. And thank you very much for your time.